Welcome, welcome everyone to Geriatric Medicine Grand Rounds. I'm glad to see all of you who could join us today. I hope you were able to relax at least a little bit over Memorial Day weekend. As is tradition, the last 4 Grand Rounds of the year are our Geriatric Medicine Fellows presenting on a topic of their choosing. And today we have Dr. Jessie Maupin, who is going to present on a really important topic that we have not touched on in Grand Rounds over the last few years. So thank you so much.
Yes, thank you, everybody. Good morning. So my Grand Rounds topic really spans 2 kind of distinct areas of focus that have really captured my interest over my relatively short career. In putting this presentation together, I sought to take a critical look at 2 fundamental facets of our identities that have at times been inappropriately incorporated into medical science, and how some flawed assumptions have informed widely accepted clinical practices, which in hindsight may have contributed to health disparities. Before we get started, I want to encourage all the audience members to participate in some interactive elements of my presentation this morning. I'll be polling the audience periodically using a website called Slido. You can access the polls by scanning the QR code on the screen there, or going to slido.com and typing in this code. So I'll be talking about how chronological age and phenotypic race of patients are commonly used as crude, and I would argue deeply flawed proxies for more relevant underlying variables that determine susceptibility to disease and how we can treat them. So through the course of this talk, I really hope to accomplish the following. I'll attempt to define what's meant by the term race and explore some common ways in which it's used in clinical practice. I'll be exploring how some researchers have described the difference between chronological and biological ages of human beings. We'll briefly review the history of how race was first defined and how this dark history can be traced directly to modern clinical decision-making tools. And finally, we'll examine how race, age, as well as poverty and even geography all intersect, and how these factors relate to frailty. So I want to start off by making a couple of assertions and observations, and I'll really use these as a springboard into today's presentation on the use of race and chronological age as clinically relevant information in the care of our patients. So first, I would assert that among the scientific community broadly, it's pretty widely recognized that there's far less genetic variability between different racial and ethnic groups than there was previously believed. As well as there's a growing awareness that race is a social construct, which is often used as a crude proxy for lifelong psychosocial experiences, which can impact health outcomes. Now, as geriatricians, our specialty is largely defined by the chronological age of the patients we care for. But we also recognize that octogenarians are not a homogeneous group in terms of their function, susceptibility to disease, and risk of bad outcomes. As I've evolved as a clinician, I've really come to appreciate that simply knowing the age of my patients is necessary, but not sufficient to fully understand the cumulative effect of their genetics and their life experiences, and how these forces shape their unique biology. So, just to kind of put out a couple definitions that are out there about what race is that I would agree with. I would argue that race is a socially constructed term used to differentiate genetically and biologically similar groups into separate categories. It's a strong predictor of many health disparities independent of socioeconomic status. Race is a powerful force in the lives of all Americans, which benefits members of the racial group in power. And it's important to acknowledge race in clinical practice, in public health, so that the biological consequences of racism can be studied and counteracted. I would also argue that race is not based in biology or genetics. It's not an accurate representation of human biological variation. It's also not a reliable predictor for the risk of heritable diseases to a large extent. There's some exceptions to that, but for the most part. It is not, I would argue, the cause for racial health disparities. And it's not static. Racial categories have really changed over time, reflecting the ways that societies alter their social, political, and historical compositions. So just briefly, for kind of prompting some thought, if we do continue to use race as a clinical variable, how is it defined? And I think this is really an important question for researchers. Do we define race by phenotype, and if so, by skin color? As we all know, there's wide variation in the melanin content in skin of people who identify as various racial categories. Do we identify people by their self-identification? There's some prominent examples of people who identify as African American when really, to all evidence, their ancestry is Caucasian. Or do we use percentage of ancestry? Again, I think this is a highly flawed concept, as illustrated by prominent figure Tiger Woods, who has a pretty diverse ancestry, yet he's commonly identified in popular culture as one racial category. So briefly, I think it's very important to kind of take a quick look back at the origin story of race to understand contemporary issues. So the practice of slavery really existed prior to the Middle Ages. It generally consisted of conquering armies, enslaving the populations of territories they dominated. As far as historians can tell, skin color really didn't play a significant role in who was enslaved. Most enslaved people were given certain rights. They could often earn their freedom over time. This was the case in Northern Africa in the 15th century. But as Western Europe really began to emerge from the Middle Ages, it used its relatively advanced shipbuilding technology to travel to West Africa. And this is really where the concept of racial hierarchy was created to justify the enslavement of West African people for the sole purpose of profit. So really, there's compelling evidence that from the very first time race was defined in the 15th century, it was intended to be hierarchical. And there's a prominent example of this member of the Portuguese court, Gomes de Zuzara, who first chronicled some encounters of people in West Africa. And he really lumped all of these phenotypical, very diverse range of ethnic groups into one category known as Black. And this was really, he wrote this manuscript as sort of a propaganda piece to make slavery of West Africans palatable to Europeans and eventually North American colonialists, to accept this concept that people with a different skin color were worthy of enslavement and not worthy of human rights. So jumping forward some 550 years, geneticists are really now able to map the human genome. And this has given us new insights into the encoded language that really defines our biology. Many social scientists were surprised to learn that at a genetic level, people of different skin tones are virtually indistinguishable, and there really are no genes for race. In fact, the genetic variation within racial groups, such as white, is actually greater than the variation between different categories that we would identify as white and Black. Through this lens, we can really see that the use of race to inform clinical diagnoses and decision-making may actually reinforce disproven notions of race as a biological construct and contribute to ongoing racial disparities in health and healthcare. So there's a growing, really exponentially growing body of work to kind of illustrate and highlight some issues with this. Really prominently in 2020, a group published in the New England Journal really kind of an overview of 12 race-adjusted algorithms that use race across medical subspecialties. And I really thought this was fascinating, and I presented on this concept earlier in the year to our psychiatry colleagues. So really this paper covered clinical calculators across the spectrum of clinical medicine, from obstetrics to oncology, and illustrated a consistent pattern of the use of non-white race in these calculators, resulting in underdiagnosis of a range of health conditions and recommendations for less medical interventions for these conditions. I'll review just a handful of these calculators during today's talk with specific relevance to the care of geriatric patients. So first, I think starting out with a patient case is really helpful. So I have I want to introduce a theoretical patient named Mrs. G to illustrate how some clinical algorithms can have a direct impact on patient care. So everyone imagine that you're seeing a 74-year-old woman in your clinic. She lives alone. She's fairly socially isolated. She has no family members who live nearby. She's become estranged from most people in her life. Her past medical history is significant for chronic kidney disease, osteopenia, hypertension, obstructive lung disease, and at least some mild cognitive impairment. Subjectively, she reports dyspnea with exertion, fatigue, forgetfulness, and she worries about falling down a lot. On exam, she's a little bit hypertensive. She has some trace lower extremity edema. She's oriented, but her memory you pick up is fairly poor. She has some stooped posture, unsteady balance. And then on exam, her expiratory phase is prolonged. She has some scattered wheezing. Taking a look at some objective data for a patient, a recent serum creatinine was 1.7 milligrams per deciliter. Her DEXA scan showed a lowest T-score of negative 2.4 in the lumbar spine. She's experienced unintentional weight loss, about 8% of her total body weight within the past 12 months. She had a MOCA score recently, which was 24 out of 30, excuse the typo there. And she had spirometry recently to evaluate her obstructive deficits, and her FEV1 was 1 liter, her FVC was 1.1 liters. Don't worry, I'll go into the interpretation of these PFTs in a little bit more detail here. So now I invite you all to engage in some participation. I just have a quick poll for the audience. And this is really looking at the concept of how estimated GFR is calculated using a couple of different clinical calculators, namely the MDRD and the CKD-EPI, two of the prominent calculators out there. So the question is, both the MDRD and the CKD-EPI equations use a race correction factor for eGFR. That's a fact. Does the correction factor, A, increase the sensitivity of detecting kidney disease in all patients, increased detection of kidney disease in white patients, increased detection of kidney disease in Black patients? Does it decrease the sensitivity in white patients, or decrease the sensitivity in Black patients? I'll give people a minute or so to type in your response there. Okay, looks like we have 8 responses, 9, 11, great, okay. And I'm now realizing I don't have a way to display the results, but we had, I believe, 3 people vote for that the calculation increases sensitivity of detecting kidney disease in Black patients. The remainder of people thought that it decreased sensitivity of detecting disease in Black patients. And the majority of respondents are right. So both of these equations will actually give a higher eGFR for Black patients, given the exact same biometric factors. So given the same creatinine and age and gender of the patient, you'll get a different GFR. And we'll explore that in a little more detail here. So the input variables for each of these calculations include serum creatinine, age and sex, as well as race. It's really just Black versus white or other. And each of these calculators have a correction factor ranging from 1.15 to 1.2 for Black patients. What that translates to is a higher eGFR given the same creatinine measurement. So this is a pretty widely discussed and publicized clinical tool. There's been a lot of discussion around this in recent years. Here at the University of Washington, or actually first I'll talk about the history of this studies a little bit more. So the original 1999 study that proposed that eGFR included a coefficient for Black patients did so on the basis of 3, I would argue, pretty flawed, small, poor quality studies. And these faulty assumptions were carried forward through later iterations. So the study said that previous studies, and I quote here, have shown that on average, Black persons have greater muscle mass than white persons. But that assertion really relied on 3 small studies published between the 1970s and the 1990s. One of these studies looked at the body composition of about 240 Black and white children and said that Black children had lower body fat and different body densities. The second study looked at about 40 adults and said that Black adults had higher total body potassium and calcium compared with white people. The third study included 60 participants who were all healthy hospital workers. And this study said that Black people had higher average serum creatinine kinase levels, which was extrapolated to higher muscle mass. So really, you can kind of see a trend here where these very small, almost I would say anecdotal studies looking at kind of proxies for kidney function were extrapolated to come to some pretty wild conclusions. So you can see here, given different ages, sexes, and ethnicities, you get a wide range of different predicted renal function. So looking at the 70-year-old adult population, if we have a 70-year-old Black female, the predicted eGFR would be about 14, whereas for a white female with the same creatinine, you'd get a slightly lower at about 12. But the discrepancy really varies, as you can see, depending on the age of our patients. Here on June 1st, 2020, the University of Washington Laboratories actually adopted a version of the CKD epi which does not use race as a correction factor. So for about the last 2 years, this has not been a practice at our institution. There are actually five different versions of the CKD epi equation available. 2 of them do include race as a factor. So there were calculators developed in 2009, 2012, and then most recently in 2021. One of the original calculation did include race as well as the second iteration, but there are other calculators out there that do not include it as a factor. So one way to kind of look at this on an individual patient level is if let's say we plugged in the same clinical variables, a 74-year-old female with a creatinine of 1.7. If our patient were white, we would get an estimated GFR of 29.4 using MDRD or 29 using the CKD epi. Now, an eGFR of less than 30 is a really commonly recommended cutoff for referring to nephrology by a lot of the professional societies. Now, if we have the exact same clinical inputs, except we indicate that our patient is of the Black race, our eGFR is now 35.6 using the MDRD and 34 using CKD epi. Now, you may say that's not a significant difference, but at a population level, how many patients are not being referred early to nephrology for discussion of dialysis, consideration of kidney transplantation? I would argue this is a pretty significant discrepancy. All right, one more poll here. This one, we're going to kind of shift to the topic of spirometry and pulmonary function measurement. So I'll open up this poll. All right, so people feel free to put in your results there. So this question is really asking, spirometry calculating software uses a correction factor for patients labeled as Black, meaning that the software assumes that normal values for Black patients are X% lower than for non-Black patients. Are people able to access this poll? I'm wondering if, there we go.
Yes, it's working.
Yes.
Great, thank you.
While we're reading the question, Jesse, this is Angela, if you wanted to share your screen, or you can just read us the results. Because
Yeah,
it's kind of a pain to like manage that.
yeah, I'll read the results. I have a couple different screens active here, so I'll report what I see. So the questions are: does the spirometry software use a correction factor of 25%, 15%, 5%, or 0? Is this actually false and that there is no discrepancy? Great. So we have nine responses, 11, 12. Great.
Oh, and I guess we see them on our phone.
Oh, you do? Okay, good. Yeah,
I didn't notice that last time.
Yeah. Good. All right. So we have this is a little bit of a trick question, actually, and it kind of depends on the age of the patients we're evaluating, but most spirometry software actually employs a range between 15 to 25% of a correction factor for patients. So 64% of respondents said a correction factor of 15%, and 21% said 25%. You guys are both correct. It really kind of depends on the age of patients, and as we'll explore, older patients are disproportionately underdiagnosed with severity of pulmonary disease. So let's jump into this. So there's some researchers out of University of Pennsylvania that have really done quite a bit of research into this. So the input variables for spirometry are age, sex, height, and then ethnicity. So usually either white, black, or Asian. I would argue that age, sex, and height are relevant. The height will determine our lung capacity, and we know that people's lung capacities and volumes tend to decrease with age. But really the question of why race is involved is a bit of a thorny issue. So the equity concern here is that pulmonary function of Black patients is effectively held to a lower standard than for white patients. This potentially masks pulmonary disease. And the history here is just really fascinating. So kind of taking a look at what this means in contemporary clinical medicine, this team of researchers from the University of Pennsylvania conducted a review of over 14,000 PFT results, both with and without race correction factor. And they actually found that the removal of race correction led to results indicating the presence of more serious pulmonary disease. The removal of race correction led to an increase in the percentage of patients with any pulmonary deficit from 59% to 81%. So what we're seeing here is an alluvial plot. This depicts the effect of Black race on the Black race correction on the degree and severity of obstructive, restrictive, and mixed defects among Black patients. So these 5 categorical axes, they represent the severity of the defect according to ATS criteria, while the separate colors in each bar represent the number of patients with the associated degree of severity when interpreted with, without, or both with and without race correction. So the general trend here we can see as moving left to right. On the left side, we have more mild severity of lung disease. As we move further right, the severity increases. By the time we get over into the severe and very severe categories, those orange bars are really indicating the amount of disease that's detected if we use the traditional race correction factors. And as you can see, that proportion of severe and very severe lung disease really starts to diminish, and virtually 0 patients were detected with very severe lung disease when race was used as a correction factor. So this really kind of illustrates that if patients have mild lung disease, these race correction factors may not be changing the results too much, but with progression of disease, we really run into underdiagnosis of patients. So to kind of look at this from a historical context, Lundy Braun has written an excellent book on this subject. And just to kind of cite from one of the chapters of her book here, she really describes the origins of spirometry correction factor dating back to the 18th century. So Thomas Jefferson actually first wrote about a difference of structure in the pulmonary apparatus in his book in 1785. He commented on how slaves appear to have decreased pulmonary capacity in order to justify the condition of slaves in the Republic. Now, defining difference as deficiency, Samuel Cartwright was a physician, prominent, wealthy, slave-owning physician, who built on Thomas Jefferson's observations and conducted extensive studies of using human subjects with spirometry. And he really, he's the one who established race as a key organizing principle of lung function measurements. Samuel Cartwright is the same physician who coined the term drapetomania, which he described as a psychological abnormality which caused enslaved people to desire freedom. And he really published a lot of results showing that in African Americans, the deficiency in their lung capacities was around 20%. There was no discussion at this time about why this was. Was it that these people were living in huts cooking over open fires for most of their lives? There was really no discussion of why there was a discrepancy, but it was used to justify this view that they were biologically different than white people. So looking at modern spirometric measurements, we can see that African Americans today are still really held to a different standard, and we'll see some common trends here. So 200 years later, that 20% deficiency that Samuel Cartwright described can be seen in modern spirometric calculating software used today. These are raw figures taken directly from the CDC website, which has reference tables for predicted lung volumes for Caucasians and African American females. For a 5-foot tall woman, the normal predicted values for FEV1 differ by approximately 20% at the younger age range, 61, up to about 23% for patients aged 61 to 80. So as we approach 80 years old, that discrepancy widens to about 23%. For our 74-year-old patient, her FEV1 is effectively held to a 22% lower standard than a Caucasian woman of her same age and height, which I found pretty striking. So now we're seeing kind of an individual patient impact of this different software. If we look at FVC, the discrepancy is even wider. So if for our 74-year-old patient, she's given a difference of about 24% of her FVC. And here we range from about 21% up to 25.9% for older African-American females. So the way this could impact diagnosis of our patient, if we had a Caucasian patient with the exact same FEV1 and FVC, we would see that she would be, based on her FEV1, she'd be likely categorized to have moderate to severe obstructive deficits. And based on her FVC, she'd likely have severe obstructive deficits. Now, looking at our African-American patient, again, same exact volume measurements, but we have different predicted normal standards. She would be given a likely diagnosis of mild obstructive deficits based on her FEV1 and a moderate obstructive deficit based on FVC. So we can just kind of compare the two here. We have two categories of severity difference in our white patient versus our Black patient. And this obviously has ramifications for when patients are both referred to pulmonology, but how early treatment is started, how seriously their disease is considered when doing preoperative evaluations, et cetera. As well as, I would say, on a population level, there's been a lot of interest in awarding compensation for people exposed to harmful compounds in occupational settings, or measuring harm from pollution on a population level. Moving on to a slightly different topic, osteoporosis, which is very, very germane to our population. This isn't a common calculator that I use very often, but the SCORE tool determines whether a woman is at low, moderate, or high risk for low bone density in order to guide decisions about screening with the DEXA scan. So the input variables here are rheumatoid arthritis, age, history of a fracture, use of estrogen, the patient's weight, and then the patient's race, Black or non-Black. Now, automatically, patients who are non-Black are given 5 points additional in this calculator just for being non-Black. So the SCORE tool systematically lowers the estimated risk of osteoporosis in Black patients, potentially discouraging further evaluation of treatment. Now, if we look at the more, I would say more commonly used FRAX tool, this has some similar issues. So of the variables here, race, including Caucasian, Black, Hispanic, or Asian, are input variables that the calculator requires. Black women are identified as having a lower fracture risk by a factor of 0.43, Asian women by 0.5, and Hispanic women by 0.53. So really, the 10-year risk of major fracture for Black women is often estimated at less than 50% of that for white women with identical risk factors. So looking at our patient again here, if we had a Caucasian patient with the exact same clinical information, our patient would have a predicted risk of 16% of major osteoporotic fracture and 4% risk of hip fracture within 10 years. This calculator would recommend initiating medical therapy for this patient based on her risk of hip fracture being greater than 3%. If we look at the same variables but indicating Black race, here you can see the risk is around 50% less. Her risk of a major osteoporotic fracture would be 7.2%, and her risk of hip fracture would be 2%. So no treatment would be recommended for our patient based on this calculator alone. Now, obviously, we take all of the patient's factors into account here when tailoring therapy, but a lot of clinicians, I think, rely on these tools for guidance, and it's troubling. In a different field, which is a little bit, I'm a little bit less familiar with, but it's also very fascinating, neuropsychological testing, which many of our patients will undergo. Race is an input variable. So in addition to age, gender, occupation, educational attainment, and geography of their upbringing, race is used here. So African Americans, it turns out, are assumed to have lower IQs as a group than Caucasians. I'll explore the history of how this conclusion was arrived at, but really interestingly, I'd say the most prominent example of how this has contributed to inequity is in a 2014 case of a lawsuit brought by former NFL players against the league. And there was a pretty widespread pattern of discrimination, I would argue. So Black players with the same cognitive scores as white players are assumed to have suffered less cognitive impairment. This policy has consequences for approximately 70% of NFL players who identify as Black, let alone all of the elderly patients with a concern for dementia out there. So dating back from the Jim Crow era, African Americans as a group have received less quality education than Caucasian Americans, and thanks to discriminatory housing segregation policies, which have historically concentrated about 20% of African Americans in predominantly all Black neighborhoods, where adults are twice as likely to be unemployed or live below the poverty line than adults in Caucasian American neighborhoods. It goes without saying that these neighborhoods have lower quality schools. And then there's the concept of acculturation. So acculturation is a complex, multifaceted concept that, in reference to poor test scores, can encompass a host of racial and ethnic group differences and substantive social exposures, including migration patterns, institutionalized housing segregation, physical health disparities, test-taking attitudes, sociocultural stress, and perceived racial bias that have hypothesized, but as yet individually unquantified, negative effects on neuropsychological test scores. So really, these are kind of some of the theories that have been used to explain why African Americans as a group are observed to have lower IQ scores. And there's kind of a lot of theories. But the scientific community has really repeatedly rationalized the observed lower scores in African Americans by claiming a biologic or genetic difference, rather than asking the question, what social, political, structural, and environmental factors could be causing these discrepancies. So just going back here briefly, I realize I skipped over some content. So it is true that historically groupings of African Americans of neurologically intact subjects have had mean scores below those for Caucasian Americans. And this is true on a wide range of neuropsychological testing. So this really provides the impetus for the creation of race norms in order to reduce false positives for African American classifications. So notably, race norms have not been created for any other racial or ethnic group, despite American Indians and Alaskan Natives also having lower test scores on average than other ethnic minorities. So really, there's no a priori reason to assume that skin color has any effect on the neuropsychological test scores of individual subjects, but the correlates of skin color may. So neuropsychologists have really hypothesized that, that some of the factors that could impact their test scores include quality of education and acculturation of people into the broader society. So that's where we really see the impact of housing policies, inferior education, institutionalized segregation, exposure to pollutants in those segregated neighborhoods. And as recently as 1994, a clinical psychologist and a political scientist teamed up and wrote this book called The Bell Curve. And in this book, these two men assert that the observed differences in IQ levels between races were likely attributable to genetic differences. So really, this is less than 30 years ago. We have prominent leaders in these fields asserting that there's some genetic explanation for why there's differences in IQ. So there's a really interesting concept which I wanted to explore, which was developed by Arlene Geronimus in the late 1980s, and this is the concept of weathering. So in the late 1980s, Dr. Geronimus was a graduate student at Princeton. Outside of her academic pursuits, she worked part-time at a school for pregnant teenagers, and she really started to observe that teenagers who came to the school tended to have far more health problems than her classmates at Princeton. This made her really wonder about the role of environment of human health conditions, and she later pursued research into disparities in maternal health between African American and white women at the University of Michigan. So she proposed that the accumulation of cultural, social, and economic disadvantages may lead to earlier deterioration of health among African American women compared to their non-Hispanic white counterparts. Furthermore, she argued that at the population level, the distribution of morbidity and mortality overall and by age is affected by resources that are allocated inequitably across racialized groups by historic and systemic racism or privilege. So, some of these resources include access to mental health resources, healthy food, access to healthcare, and then different features of the built environment, including toxic environmental exposures. So Dr. Geronimus has really become a leading kind of scholar in this area, and she's continued her research to modern day. So she's researching the social and biological processes that may underlie weathering, and is a vocal advocate of the concept that structural racism is a major contributor to healthcare disparities. So she kind of conceptualizes weathering as the cumulative biological impact of lived experiences from conception to current chronological age. So this is really kind of where you start to see this concept of age and race kind of intersecting to have really profound impacts on our patients. So this model argues that health is dynamic across the full life course as biopsychosocial mechanisms link poverty, discrimination, and political oppression to biological wear and tear, disease, and longevity. She published a really interesting study in 2020, pretty recently, where she looked at, they collected and analyzed a unique data set of residents of the city of Detroit. So this was a pretty intensive study where they checked biomarkers from all of these participants through blood draws and extensive interviews. And they were attempting to measure something called the allostatic load, which I'll talk about further, which they argue is an indicator of stress-mediated biological dysregulation of their participants. So she was really trying to quantify at a biological level, what does a lifetime of experiencing, being a member of a subjugated racial class, what does that do to our biology, and can we quantify it somehow? So they measured 14 biomarkers, and they kind of established cut points for what was a high risk threshold. So you can see the biomarkers here, and I'll talk about some of their results in the next slide here. So so this bar here, this bar graph represents the disproportionate difference in allostatic load scores that they were able to assign to poor versus non-poor white and Black Americans from this study in Detroit. So the allostatic load scores for poor white and Black Americans are really quite similar. You can see the orange bars there are for individuals with a poverty income ratio of less than 1, which is how they defined poverty in this study. And you can see the allostatic load scores are pretty similar. So poor residents, it is intuitive that may have higher physiologic stress on their bodies. But what's really interesting is looking at non-poor white Americans are 39 percentage points less likely to have a high allostatic load scores than the white poor. So we see essentially wealthy or white people not living in poverty are experiencing less of this physiologic stress as they measured it. On the other hand, non-poor Black Americans don't have that significant difference. They still have relatively high allostatic load scores when compared to the Black poor. So even when adjusted for poverty income ratio, the relative odds of Black Americans having an allostatic load of greater than 4 was consistently higher than for white Americans. And the discrepancy widened with age, as I'll show on the next slide. So really this raises the question, what could account for the discrepancy in allostatic load that's not explained by socioeconomic difference here? Many researchers feel that the weathering effects of racism explains why such high rates of Black people are not living, who are not living in poverty, have very high allostatic load scores. There's a really interesting spin-off study from this publication where the same team of social science researchers teamed up with some cellular biologists, and they actually measured the telomere length of these same study participants. Now they used regression models on telomere length, on socioeconomic, psychosocial, neighborhood, and behavioral stressors. And they actually found an interaction between poverty and racial ethnic groups. What they found was that poor white people had shorter telomere length than non-poor whites, but poor and non-poor Black people had essentially the equivalent telomere lengths. This is a pretty small sample size, about 250 patients, but the results were pretty compelling to sort of look for a different physical, actually genetic marker of physiologic aging. Telomere length has kind of been described as one of the hallmark signs of aging that can be quantified across the life spectrum. And I'll also point out here that that maternal health scores have really been observed where wealthy African-American women have very similarly poor maternal health outcomes when compared to African-American women living in poverty. And you really don't see that same difference among white Americans. So earlier work performed in 2006 by Geronimus and some of her co-researchers also demonstrated a widening gap between the measured allostatic load scores for Black and white Americans as they aged. So using National Health and Nutrition Examination survey data, they examined allostatic load scores for adults aged 18 to 64 years, and they actually found that Black patients had higher scores than did whites and had a greater probability of high score at all ages, particularly from age 35 to age 64. So these racial differences were not explainable by poverty. They used 10 biomarkers in this study for inclusion in the algorithm. So the 10 biomarkers they used were systolic and diastolic blood pressure, BMI, hemoglobin A1C, albumin, creatinine clearance, triglycerides, CRP, homocysteine, and total cholesterol. When they performed logistic regression for the full sample by race and gender, Black people had a higher probability than did whites of a score greater than 4 at all ages. Furthermore, the size of the Black-white gap increased with age. So we're really starting to see this kind of intersection of race and age kind of having an amplifying, kind of concentrating effect on these physical stressors. So here I think it's really pertinent to kind of introduce this concept of intersectionality, which was first coined by Kimberly Crenshaw in 1989. She really described this as a way to define how the multifaceted components that comprise us as human beings can intersect. This theory really argues that no individual facet of human identity can be considered separately from the sum of their parts. Each aspect intersects with and influences the other. So for example, it'd be correct but not sufficient to describe our patient Mrs. G as a woman, right? That's correct, but there's more to it than that. It'd be far more accurate to describe her as a 79-year-old Black woman with dementia, chronic kidney disease, osteoporosis, social isolation, and food insecurity. That really gives us a much fuller picture of who she is and some of her risks. As an aside here, this is not an endorsement of including race of our patients in the sort of one-liner that medical students are trained to present during the medical training. This is really kind of a controversial topic, which I really won't get into today, but there is a role for recognizing race in the clinical care of our patients, but it shouldn't necessarily be highlighted in our sort of initial presentations of patients. So this is a really interesting 2015 study by Karen Bandine Roche from Johns Hopkins that employs National Health and Aging Trend Study, the NHATS. And this provided a nationally representative sample of Medicare enrollees age 65 and older. So this study employed the Frailty phenotype, which is a popular and validated tool. It was applied to about 7,500 participants to obtain weighted estimates of frailty prevalence. What's really fascinating here is they show age-adjusted frailty prevalence by income quartiles, white, black, racial ethnicity, and different geographical regions as defined by the United States Census. So this study breaks down participants into 4 quartiles of income. So we have lowest quartile at the top, indicating the poorest patients, and the wealthy patients at the bottom. And then on the left column, we have white participants and black participants on the right side. And then you can see different geographic distributions of their frailty prevalence. What's really fascinating here is you see not only a trend of increasing frailty by poverty level, as may be expected, but there's a pretty stark difference in the different columns by race. And then you can see different geographic differences. So here in the Pacific region on the West Coast, we tend to have moderately high frailty levels compared to the Midwest states just next door tend to have lower frailty rates. Whereas in the Southeast, they tend to have, on average, higher frailty rates. And then you can really see this pretty stark difference by ethnicity as well. So I recognize that telling a bunch of geriatricians that age is just a number is kind of the definition of preaching to the choir. But at the same time, it kind of goes without saying that chronological age is extremely relevant to the medical care of our patients because it serves as a proxy for biopsychosocial experiences, predictable anatomical and physiological changes of aging, and the accumulation of a range of deficits in homeostasis. So much like how race has been used as a proxy for approximating the allostatic load of patients, I would argue that age has kind of been used as a proxy for identifying frailty in patients, though it's not a perfect proxy. So I'm going to now transition to talking about frailty and how frailty has kind of been studied for this purpose. So there's really two different conceptual frameworks for frailty out there. On the left, there's this kind of idea of phenotypic frailty, which was exemplified by the Fried phenotype, or also known as the physical frailty phenotype. And this can really be measured by detecting 5 key variables, including grip strength, walking speed, unintentional weight loss, and asking patients about how fatigued they feel and what their physical activity is. This was really described by Linda Fried in her extensive research into this topic. On the right side of the screen, there's kind of a depictor of the cumulative deficit model, which was hypothesized to be driven by the cumulative non-specific health, functional, and psychological and cognitive deficits. And this model really has numerous frailty detection tools, including the deficit accumulation index, which includes 40 different discrete variables used for research purposes a lot. There's a lot of other tools that are kind of included in this category that I'll discuss here. But really, I think this is kind of a helpful way to think about frailty, of how you can observe it on the left. You know, we can see a patient and pretty quickly we can come to the conclusion that they're frail, but that doesn't really get to the underlying cause of what caused this patient to be frail. On the right side, we can really start to quantify all of the different inputs that can go into causing a patient to become frail, which is exemplified by this phenotype. So one more last poll here for the audience. If you can hop over to the website here. And this question asks, which of the frailty estimation tools have you personally used in the past 12 months? So really not a right or wrong, just kind of trying to get a sense of what the audience here has, if they're familiar with some of these tools and which ones they prefer to use. All right. We have 7 responses so far, 10, there we go. Yeah, so pretty wide range here. It seems like most of these frailty tools have been used by people in the audience. Yeah, the CFS Rockwood clinical scale kind of taking the bulk of the prize here. Okay, great, but we have a good variety there. So yeah, 77% of you said that you've used the Rockwood Clinical Frailty Scale. 8% have used the Edmonton Frail Scale. There's a couple of modified Frail indexes out there. 31% of you have used that. 8% have used the Frail VIG scale. And then the Karnofsky Performance Status Scale, 36% of you have used. Great, all right. So jumping forward here. So I wanted to kind of really explore the history of the most widely used clinical frails, the CFS, the Clinical Frailty Scale, which most of the participants have used and which is very widely used throughout geriatrics, I would say. So the complete name for this tool is actually the Canadian Study of Health and Aging Clinical Frailty Scale. This was developed by a team led by Ken Rockwood at Dalhousie University in Nova Scotia. In 1999, they first published a research letter in the Lancet describing the earliest version of the CFS. And this was actually based on the classification scheme of the geriatric status scale, which was a tool used to assess hospitalized patients. So these patients were classified in just 4 different categories. And that basic frailty model did show a dose response between grades of frailty and subsequent institutionalization and death. So this was sort of the first kind of iteration of the CFS. Moving later 3 years to 2002, Rockwood's team published the Frailty Index, which was a composite score of 70 different subjective and objective variables. Now, these variables were later refined down to about 40 variables, as shown here in this table. So this frailty index is really just defined by, you can calculate it by dividing the number of health deficits present by the number of health deficits measured to give you a score or a number. And this tool was replicable across multiple large aging databases, including the Canadian Study of Health and Aging and the Yale Precipitating Events Project cohort study. And this has really become the standard process for creating frailty indices for research purposes. And it's been replicated across numerous iterations. Now, this frailty index is really reproducible, but it's really not employable in a clinical setting due to its unwieldy size with 40 different variables. So they really wanted to create something that could be employed rapidly by clinicians in clinic. So the early version of the CFS is born. The first iteration came out in 2005, and it was really intended to be a measure of frailty based on clinical judgment without the cumbersome tallying of dozens of health deficits. So the CFS was validated by this publication later in 2005, and they showed that each 1 category increment of the CFS increased the medium risks of death and institutional care. So this is what the CFS initially looked like in 2005, but it's undergone 2 actual major revisions. So in 2007, it was expanded from a 7-point score to a 9-point score. They recognized that they needed to include these 2 final categories because they were pretty clinically distinct. And then they also in 2020 changed the definition of some of these categories. So they redefined well to fit. They redefined vulnerable to living with very mild frailty. They added living with to these 3 categories. So they kind of just slightly tweaked the definitions of these categories. So I'm going to kind of wrap up here. I think it's really important to think about the intersecting accumulation of pathology when we think about our patient here, Ms. G. So people are really more than the sum of their parts, and no individual characteristic whether it be chronological age or skin pigmentation, should be relied upon to serve as a proxy for perhaps dozens of individual unique components that comprise patients under our care. So in an ideal world, we may be able to use a multitude of biopsychosocial factors as a better proxy for race, but these can be difficult to employ in the clinical setting. In a 2019 JAMA publication, this team laid out a 4-part litmus test to justify the use of race in clinical care. So they sort of argued that the use of race should confer substantial benefit. It cannot be achieved through other feasible approaches. And patients who reject categorization of a single racial category should be accommodated fairly, and that the use of race be defined transparently. Now there's a group out of Yale that published a paper in the Lancet in 2020 that really laid out some arguments for using a race-conscious rather than a race-based approach. And these are really some of their arguments: that racially tailored practices that propagate inequity should be avoided, medical education should recognize these disparities, leadership should adopt resolutions to denounce race-based medicine, and clinical researchers should really examine structural barriers rather than just using race as a proxy for biology. All right, these are some of the references that I used, a couple websites. Thank you all. And finally, here's a QR code that you can find the evaluation for this talk.
Thanks so much, Jesse. If anyone has questions, feel free to unmute or to type them in the chat if for some reason you can't unmute.
Jesse, I have a question. Has anyone looked at older versus younger Americans' perception of their race? For example, I have older patients in senior care clinic who differ greatly in their feeling about being here for 300, 400 years versus recent immigrants, and they feel quite strongly about it. And it's a little bit, I get a little taken aback. I'm not sure what to say, but they feel as if they should be somehow recognized for that difference, and that it's important difference for them.
Oh, so they're making a distinction between their being kind of naturalized citizens versus born in the country?
That's right. Well, that their experiences, what they've been through for the past 200 to 300 years in the United States is very different from patients of mine who have come here in the last even half a century, and that they want that recognized and they want that appreciated. And I just don't know what to say to them.
Yeah, no, that's a really good question, Dr. Reed. And there has been, I almost did include some studies on the perceived racial discrimination that people experience. And there is actually a very strong correlation between the perceived level of discrimination and some of their health outcomes. I didn't include those studies in the talk, but there's also really interesting evidence that I've come across that some immigrant populations to this country, for example, West Indian immigrants tend to have better intergenerational wealth 2, 3, 4 generations into their family's arrival in this country. And there's a lot of theorizing that, there's trauma and kind of intergenerational discrimination that's passed down through the family, possibly on a genetic level, and that the accumulation of wealth has really been stunted by patients whose families have been here since colonial times. So I don't have any data to share on that, but there is a lot of interest in that area.
This was a fabulous talk. Thank you.
Thank you. Yeah, Angela.
Hey, Jesse, thank you so much for such a comprehensive and giant talk. This should be an all-day seminar, really. Quick question. So for some of the data that you presented at the beginning, so with the creatinine clearance, it looks like, most of that is being phased out in terms of race. But in terms of like DEXA, or sorry, not DEXA, but Frax risk, and then like the PFTs, I guess when you're calculating the Frax risk, you could just leave race out and just, or you could put white and black race and just say your risk is somewhere between here and here, or go with the highest estimate. You know, if it puts them in a bigger category, if changing their race to white puts them on in a different risk score, you could give that counseling. And then, but with the PFTs, are there any absolute numbers on there that you could like look at, like the DLCO that doesn't rely on anything? I'm just wondering, as a scientist, like what we do with these numbers, or yeah. So
Yeah, no, that's a really good question, and you're right. I think there is a big movement to encourage clinicians to just not select race as a variable, because in the vast majority of these calculators, Caucasian is considered the normal default, meaning non-white patients are
we're the
given.
minority in the world.
Right. Yeah. So Caucasian is sort of considered the standard. So there's a lot of push to just not including the non-white race of patients, and then you'd get maybe a better sense of just the biologic risk. For PFTs, I believe it's the same. I believe Caucasians are used as the standard, so you could just leave that factor out. But for DLCO, I didn't actually see racial differences in there. It was really about the measured capacities that patients need to perform. So that's a good question. I'm not sure if DLCO has a correction factor.
Yeah, I'm just trying to think of how they report out PFTs. Like, you know, there's a lot of data that you get that's like raw numbers and then computed numbers. Like when we look at our PET scans, we have the raw read and then the rendered stuff, and then the, you know, like, is there raw data that we can just look at and forget the interpreted scores? And same with neuropsych testing. Like, forget, just give me the raw numbers. How many fruits did they say? And let me interpret it. Thank you.
Yeah, and I actually spoke with a pulmonology colleague of mine who told me that when he actually receives PFT results, the technician is the one who enters race at the very front end. So when he receives the raw numbers, it actually does have that race correction factor built in. So he started asking his technicians to either not include race or give him both sets of numbers. Yeah.
It looks like David has his hand up.
Oh, yeah.
Thank you, Jesse. This is just such important information, and it got me thinking about other aspects of clinical care where we need to rethink our approach. And just one example that I can recall is a decision about antihypertensive medication based on race, and should we choose an ACE inhibitor or a calcium channel blocker, and how that decision was supposedly informed by the race of the individual. So it seems like we have a broader issue of rethinking our approaches and the underlying rationale.
Absolutely. Yeah, thanks for that, Dr. Grunwald. I can recall as a medical student, I don't remember if this was a formal part of the curriculum, but I remember being told that African Americans on average have a higher activation of their RAS axis, the renal angiotensin system, because of the people who are more likely to survive the transatlantic slave trade retained sodium at higher levels and could survive dehydration and malnutrition. Turns out that really has been debunked in recent years, but I remember that was kind of a part of the curriculum to justify differing treatments for African Americans. So yeah, I think there's a lot of kind of re-education that is on us as clinicians to kind of explore.
Great. Well, really wonderful presentation. This was fantastic, Jesse. Thanks for putting this together. It gave us a lot to think about and a lot to work on. And I really appreciate this discussion afterward. And it sounds like you're going to be asked back for many a talk to expand on this. So thank you so much. Thank you, everyone, for the discussion. And we will see you next week at Journal Club.
Great. Thank you, everybody.